Ella, thank you for this brilliant lecture. So I understand that personal medicine for the oncologist means the selection of drugs during the molecular profile of the tumor, and for the surgeon means selection of the proper surgery that fulfills the criteria how to remove the tumor. Let's see how can we combine the two approaches. And maybe I would start with some examples, okay? Maybe I'll start with you, Ayala, and tell me what's your recommendation for a patient who has carcinoma of the sigmoid colon, okay? Is a 55-year-old man, okay? In whom preoperative diagnosis confirms the presence of a single metastasis in segment 2 of the liver, a 3-centimeter metastasis confined to the left lateral segment of the liver. PET-CT disclosed no other foci of metastasis. And intraoperatively, the tumor appears to be confined. There is no peritoneal or omental spread. And the single liver metastasis in the left lobe appears easily removable without any cost of real morbidity and mortality. What's your recommendation for the surgeon?
Assuming that the tumor in the sigmoid colon is not obstructing or not bleeding heavily, so there's no need for urgent surgery. You want to comment about that? No,
go
there's
ahead.
No need. So I think based on the URTC study, we should start with 6 cycles of Folfox definitely, but I wouldn't, start with Folfox only today. I would do KRAS mutation analysis and upfront and add a biological to the Folfox, either bevacizumab if you have mutation in the KRAS, or cetuximab or panitumumab if the KRAS is not mutated. I want to remind you that even if he's going to surgery and then coming back to me, he will get the same number of courses. I'm not giving him additional chemotherapy. It's the same 12 courses we traditionally give. I'm just saying 6 courses before and 6 courses after.
Good. It's a bit unfair because the vast majority of the people here are surgeons, but I would like to ask the audience who would recommend surgery first for this patient. Okay, it's a bit unfair. It's a bit unfair. Could you, Ayala, cite an article that does not compare surgery alone without any oncological treatment, but surgery with no adjuvant treatment to surgery with adjuvant treatment regarding the outcome of these patients? Would you take into consideration the possibility of 5% advancing disease during the period of 3-4 months waiting?
Yes, I'm taking it into account, and I'm saying that those patients, I don't think they gain any substantial benefit from the surgery, because we have to assume that under Folfox with biologic, this patient progressed that much that the surgeon's telling me after 2 months he cannot operate on me. And I would say this is very aggressive disease. Most probably multiple metastases that we don't see micrometastases, and this patient will gain his overall survival benefit if from systemic therapy and not from surgery. So yes, I'm taking it into account.
Okay. Do you see all surgical patients before operations?
Only those that refer to me.
Okay. Okay, I'm a bit relieved. Okay. Okay. I would like to ask you, Professor Ewing, another example. Okay?
Just comment on this one, because I think it's important.
No, we'll have an open discussion later on. I mean, it's a debate, so we need some arguments. But it's legitimate, it's absolutely okay. But I would like to give you another example. This time, it's a 68-year-old woman. She has carcinoma of the rectosigmoid. Quite a bulky tumor. And also, she has a sizable tumor in the right lobe of the liver, in the center. of the right lobe of the liver actually occupying the hepatic vein on this side. What's your recommendation? Single metastasis, single liver metastasis.
Well, it's a wonderful example, okay, but let's go back to the first one. Right?
No, you addressed my question first.
Okay. Okay, the first one needs surgery. This one needs chemotherapy.
Okay.
I think that was the design of your question, okay, because both of them are synchronous disease, which is by definition progressive disease, okay? But the first one is a minor, on the minor side of the spectrum, okay, on the light side. And this one has clearly progressive, bulky disease. The primary tumor is in the rectosigmoid, left-sided, down, low, and the liver metastasis is a big one, which requires probably major hepatic resection, right lobectomy, combined with anterior resection. It's a heavy burden operation for a 68-year-old woman. So I would go with chemotherapy first in this case.
To achieve what?
To achieve, first of all, to achieve all the advantages of neoadjuvant chemotherapy. Okay, first of all, to achieve shrinkage of the liver metastasis, allowing for an easier, okay, resection. Probably, if he responds, I would go to the liver first and leave the rectosigmoid unless it's symptomatic, okay? If it's asymptomatic, I would go to the liver first, and then maybe on a second stage go to the rectum.
So as I understand, even after the neoadjuvant setting, you would not dare to combine the two major surgery together in this 68-year-old woman.
Well, I cannot say as a rule.
Okay, but that's your tendency.
Tendency, although we published a series of synchronous or simultaneous resection with low anterior resection and major hepatectomy, which were done safely, but obviously it's a risk, more than doing a left lateral wet resection and a right call. So
Okay.
to tailor it.
Okay, so tailoring a solution in liver involvement with colorectal cancer means that we have to take into consideration oncological and also patient ability to tolerate surgery. Okay. I would like also to ask your opinion about a different aspect. You do quite a lot of hepatectomies, okay? Some of the extended hepatectomies, especially more than right hepatic lobectomies, take sometimes a couple of months, even more, to regain their strength. It's a very demanding, energetic operation. Takes time to recuperate, and many of these patients cannot tolerate systemic chemotherapy some 3-4 months after surgery. Do you take this into consideration before you decide upon surgery first or oncological treatment first?
Sure. I played my role as in this debate, okay, but in reality, the key answer to the debate is the multidisciplinary approach, and this is a good example of a patient that we might consider strongly to start with chemotherapy, although surgery is feasible. But when the disease is bulky, okay, I would be liberal to start with neoadjuvant.
Okay. I allow when you see a patient, when you do this multidisciplinary team approach, and you have a patient with a remarkable steatohepatitis before treatment, fatty liver, so-called, very common, and it's an epidemic. Some 40 to 50% of our patients have extensive fatty livers. Do you take this into consideration regarding selection of treatment?
Yeah, well, as Professor Yorim said, I was playing my role also, so we definitely in the day, every day, we are not as definite as we are here, and we're taking into account all parameters of the patient. Of course, the first patient you presented to me, if she had or he had a fatty liver, I would think that the chance of getting complication after surgery is too high for me to risk him. And for this patient, for instance, I would go first surgery and only second for adjuvant chemotherapy. So yeah, you give an example. It was an extent example for both directions. So the truth is usually in the middle. And it's truly, truly in multidisciplinary team, this is the answer.
So it's really a dance between
Yes.
teams and a selection of decision-making according to what the patient really present to us.
Right.
Okay, and it shouldn't be so strict.
It's not actually.
Okay, very good. So it's open for discussion, for open discussion now. Please, questions.
What about the same type of patient that you're talking about here, but let's say that it's a rectal cancer, a locally advanced rectal cancer, so T3N1 rectal cancer with disease in the liver. What's the role for addition of radiation therapy to control the primary disease at the same time that you're trying to control the metastatic disease with chemo? Do you ever do chemo, then radiation, then more chemo? Do you ever do radiation first and then the chemo? Where does it fit? Because that's another parameter when you're dealing with the rectal cancer that even complicates things further.
I think in those cases you might use the Scandinavian protocol and try to do the short-term radiotherapy and
Enhanced radiotherapy.
and make and schedule your treatments accordingly.
It's true, this is the worst cases in our staff meetings. These the rectal cancer patients with locally advanced disease and liver metastasis. I mean, we're changing the protocol once a week. And I think we're doing more and more starting with systemic therapy. And after, 2 to 3 months, reassessing the patient and dare to first change the schedule of the operation to even operate the liver first and the rectum second. I mean, this is the recent years we're doing. And in some patients, the rectal cancer responds so well that we can even do the surgery on the rectal cancer after chemotherapy and add the radiation therapy later. But I mean, it's again, judged by every patient, different procedure. But I just came back from meeting in Barcelona, and more they were pushing toward systemic therapy first, and then reassess, and then to see what the patient needs further on.
Ayala, you mentioned right that in some proportion of patient complete response is observed. I think it's actually with the modern approaches and protocols, it's even higher than the 3 to 6% that you mentioned.
This is chemotherapy only.
It may even reach 20%. We combine with Avastin and chemotherapy. Do you mark your metastasis prior to the chemotherapy or the oncological treatment, fearing that the metastasis will vanish and will make the work of the surgeon actually impossible?
Yeah, we the oncologists do believe that every site that had metastasis in it on the beginning of the treatment should be resected, even if it was cleared up totally by CT scan or PET scan. And we're looking for a way to mark it. I know there is a way to, put a under ultrasound or CT
Yeah,
scan.
like in the breast. Just put,
exactly.
Yeah, like in the
Yes.
breast. Put in the middle
Yes,
of the lesion.
it's true. We haven't done it yet in Hadassah, but we're talking about it. So, are you doing that?
Yes,
Yes.
of course.
So
From
we are
time
not-
to time.
From time to time. I think that the worst cases are those that have big metastases along with very small one next to it. And you know that if you need to shrink the huge metastases, the little one might disappear meanwhile. And yes, they need marking. I do agree.
I was just going to comment that there's already data for preoperative chemotherapy alone in rectal cancer from Deb Schrag, which has response rates, as you said, about a quarter CRs. And this hypothesis is being tested in a large prospective trial in the United States of induction chemotherapy alone without radiation versus chemoradiation followed by operation. And the patient who was just asked about, who has liver metastasis and a rectal cancer, and I think in most places would receive chemotherapy alone as initial treatment because they have stage 4 disease by definition. You would make the call as to whether the liver metastases were resectable or were not resectable at initiation, and they would be reevaluated after induction chemotherapy for a decision regarding section, just as Ayala said. I think last, it will be in the future, I think we'll use genomics to predict not only who will respond and who will not respond, but who will be cured by surgery alone versus who will not be cured by surgery alone. And there will be patients with a very high likelihood of cure with surgery alone who will not receive systemic therapy, and patients with a very high risk of recurrence who will receive chemotherapy.
Nowadays, the response to neoadjuvant treatment appears to be a huge prognostic factor in patient outcome. And those who respond, especially those who respond dramatically, will do tremendously good regardless of further treatment, including surgery. Okay, more comments?
Can I ask you, I'm still a little unclear what to do with that patient who has an asymptomatic colonic primary. Forget about rectal for the moment because that's a separate issue, but an asymptomatic colonic primary. It does appear that they go through a period of adjuvant chemotherapy or neoadjuvant. Should we be influenced by the endoscopic appearance of these patients? It looks as though less than 10% of those patients convert to a colorectal emergency, either obstruction, perforation, or both. But it's that patient that we seem to be seeing quite a number of. Maybe we're super selecting some of these cases by their initial chemotherapeutic approach who present with metastatic disease. And I'm still concerned that we are seeing patients who have colonic perforation or colonic obstruction or both as an emergency where the mort rate is actually very high. Should be influenced by endoscopic appearances. If they can't be traversed, for example, at endoscopy, should they be electively stented these patients, at least to prevent one of the acute colorectal emergencies?
Good questions. You mean preventive stenting?
Yes, I guess I do. We seem to be, either these patients go, as we've seen even in this discussion, off to the surgeon or off to the oncologist, and there's kind of this loss of communication a little bit about those patients who clearly are coming along. And I can just think that I've seen 2 in the last month now who've presented with a small, essentially asymptomatic primary, at least at the start of their treatment, and who've presented as major colorectal emergencies. It looks from the literature as this number is fairly small, less than 10%, but it does seem that we're seeing certainly in tertiary referral centres very selected patients who actually are doing rather badly on this schema.
Maybe the solution should be then to operate on them first.
That's what I believe.
Okay.
But I don't know what other people
Okay.
believe.
Ayala and other oncologists in the audience, do you really see complications of the primary tumor with chemotherapy regimen with and without Avastin, especially ulcerated tumors?
Again, this is one of the part of patient selection. So we always have the surgeon opinion once we're deciding, because we need to know that the tumor is not on the verge of obstruction. I will not take a patient like that to receive bevacizumab, of course. So if I really, really think strongly that I prefer the chemotherapy first and not surgery first, I will choose, if you have no mutation in the KRAS, the cetuximab. And if mutated, maybe I will start without bevacizumab. and make sure that only once he responds and the obstruction is not as much, I will add the bevacizumab later. We don't see it as much. We honestly don't see it, and I really think that the memorial data showed us that even for long-term patients, most of them does not need stenting and does not need operation, and we can save them the operation, of course, if they don't have obstruction. And for the neoadjuvant patient, which is really for a short while, I don't remember that we had problem. Again, patient selection.
Mickey, please.
My question is to Professor Urim. Why, after chemotherapy, why didn't he first resect the colonic tumor and then went to the metastasis, which can cause prolonged problems? I would think that you first resect the colonic tumor. It's a very short, procedure. Within a week or two, the patient will most probably do well, and then, or not, and then attack the hepatic tumor that shrink, and which the post-operative of this one may be much longer.
Okay, it's a very good question. So you are actually afraid, if I understand well, that leaving the primary tumor behind while treating only the metastasis may actually risk the patient by further shed of tumor cells from the primary tumor and further metastatic spread. And local problems. So you recommend to do the primary tumor first. Yechiel Ziv.
This problem was discussed in the last American Society Congress
I'm sure.
last June, and the answer is no answer yet.
As expected. Okay. Okay.
But the reason is that the notion is that the prognosis of the patient with metastatic disease is the liver. Okay? Long term. So that's why we go to the liver first. It's a tendency that developed during the last few years. Usually we did suggest that you go to the primary first, then you go to the metastasis, or you do it simultaneously. But now in selected cases, it's not that an overall approach, but in selected cases where the tumor is completely asymptomatic, and especially the liver metastases are dominant, but still resectable, then we go to the liver.
But still you agree that the convalescence period after hepatic resection is far longer than after colectomy?
Not always. Livers don't leak.
Major liver resections.
I don't know. The patient, survived the operation well, and he's not, handicapped. Usually they recover very well. Also, it's very individual, but it's not the major consideration.
Alon, are we over the limit now?
We're perfect, and we should get to the next session now.
Okay, thank you very much.